Good morning, everybody. I would like to thank Professor Fabbri for giving me the opportunity to chair this session on monoclonal antibodies, which I think represent a real innovation in terms of technological innovation and pharmacological innovation. So I introduced the first lecture by Professor Chung on monoclonal antibodies in severe asthma. Thank you.
Yeah. Oh, thank you. Oh, thank you, Professor Matera. I again thank Leo for inviting me to speak here on 3 separate occasions, and I'm very pleased to know that this is my final 3rd talk, and this talk is about some real advances that has occurred over the past 10 years in the introduction of new, more effective therapies, which has come about very much in terms of understanding the various phenotypes that underlie severe asthma, which is the topic I'm going to talk about. And it's also a lesson into how it is really important that we understand what different types of phenotypes and what different endotypes, in fact, because endotypes really have to deal with mechanisms in getting new treatments. So these are my conflict of interests. So my first slide, which is not as elegant as some of the slides that have been presented by Guy Bruxelles, really sets the scene, because it shows what we understand about the mechanisms of severe asthma at the moment. And of course, this slide doesn't mean that we know everything about all the underlying mechanisms of severe asthma, but work that has been conducted 20, 25 years ago, and some of that work was done at my institution, particularly by Barry Kay, focused on these Th2 cytokines, as we called them at that time, but now they are more in terms of T2 cytokines, because this family of cytokines, IL-4, IL-5, IL-13, which were originally thought to be mainly contributed by the Th2 lineage, we now know also, as you've heard, is contributed by those ILC2 cells, and therefore it's much better to call them T2 cytokines. So at that time, Barry Kay and other groups showed the importance of those cytokines in the pathophysiology of particularly of allergic asthma and also of non-allergic asthma, and so put them on a map as being a very important group of cytokines for asthma. And then later on, a work that looked into molecular phenotyping of asthma indicated that the Th2 induced cytokines or genes, those that express very high levels of those genes were linked to a particular group of asthmatics that was associated with eosinophilia and with good response to inhaled corticosteroids. And obviously, we don't only have those groups of cytokines that have been that could be linked to asthma, but there's also a large unknown area, which is now classified as non-Th2 or non-T2 type cytokines, of which would be cytokines that are derived from possibly Th1 or cytokines derived from Th17 cells. And these also have been areas of interest in terms of developing antibody treatments to those cytokines. But of course, these are very specific directed treatments. And one of the big issues has been to which type of patients would respond to those treatments. The other thing that has to be said is that each of those cytokines, although they're grouped under the Th2 umbrella, have slightly or have different effects in asthma. So IL-5 is mainly an eosinophilic directed cytokine that causes terminal differentiation of eosinophils in the bone marrow, and also to some extent a chemoattractant, and also can activate eosinophils to a certain extent, while IL-13, for example, has more effects on airway smooth muscle. And in fact, the first paper that was published in Science about the effects of IL-13 emphasized the effects on inducing bronchial hyperreactivity, and subsequent studies have shown that IL-13 can activate airway smooth muscle, both in terms of contractile response and in terms of inducing other cytokines, and also inducing proliferative mechanisms or like TGF-beta on the airway smooth muscle, so that IL-13 can really very much be linked to those other non-Th2 mechanisms that can be put under the umbrella of airway wall remodeling, as you can see here. So, with this sort of background, I think we move now to the current situation, which is illustrating what are the compounds or the antibodies that have been developed to target those Th2 and the T2 and non-T2 targets. And so on the T2 targets here, I think what I will talk about are those antibodies against IL-5, mepolizumab, reslizumab, which are undergoing, in fact, mepolizumab is already approved, and in fact, in the UK, I know that, or in Europe, I think we will have them pretty soon this year. Reslizumab and IL-5 alpha receptor antibody, benralizumab, and IL-13, lebrikizumab and trastuzumab. And of course, I won't talk about anti-IgE because this is already available and an established treatment for severe asthma. Then the IL-4 receptor alpha, which in fact, when you target this receptor, in fact targets the effects of IL-4 and IL-13, and dupilumab is one that's undergoing advanced phase 2 and 3 studies. The non-T2 is concerning IL-17 antibody, IL-17 receptor antibody, TNF-alpha antibody. And I won't talk about this one because this is a small molecule antagonist, although its effects would be worth mentioning. So I'm going to spend a bit of time on mepolizumab, which, as I said, is going to be available for our patients with severe asthma this year. And really, I think it's important to really go a bit through the history of this compound. And the first study, clinical study that was done, published in The Lancet in 2000, which was a study on the late asthmatic response as the primary outcome. And many of you will know that this study was negative in terms of this outcome, the late asthmatic response. In that study that was performed in 3 different centers in the UK, and a paper headed by first author by Maggie Leckie, who now works in McMaster. In fact, Maggie was the fellow that I recruited to this study at the Brompton. But the main findings of this study was that mepolizumab was a very effective drug in terms of its anti-IL-5 effect if we measure the mean blood eosinophil count, which was reduced very significantly, nearly suppressed the circulating eosinophils, and it also inhibited, to a certain extent, in fact to a large extent, the recruitment of eosinophils into the lungs as measured by induced sputum, from 12% to 0.9%, and yet this antibody did not inhibit the late asthmatic response or any airways hyperresponsiveness to histamine. And indeed, I was quite impressed by the commentary that accompanied this article in The Lancet, in that it said, targeting cytokines in asthma therapy, round 1. And that was an optimistic attitude to take, and it was a good attitude to take, because a lot of people, having seen this study, would probably not put their money on that antibody. And this article was really got a lot of scientists back to the drawing board and discussing as to whether eosinophils were really important in asthma. And a long amount of debate occurred, and until and GSK, in fact, despite this negative study, went on to do a clinical study to evaluate the efficacy of mepolizumab in patients with moderate persistent asthma. And again, in this study here, you will see that there was good efficacy in terms of inhibiting the blood eosinophil count, but the primary outcome they were looking for, FEV1, was not changed at all. And this was in a group of mild to moderate asthma, taking a certain level, or the maximal level of ICS of 1,000 microgram per day, with a certain amount of daily symptom score. So a general type population, which was not really phenotyped to any particular extent, as to the eosinophil. So you see the conclusion was that mepolizumab doesn't appear to have significant clinical benefit, and further studies are needed to investigate the effect of mepolizumab on exacerbation rates. And the reason why they mentioned this was because there was an inkling there, when you look at exacerbation rates, that there could have been an effect, but it didn't reach statistical significance. And there was still a very positive outlook from that study. And I put it emphasizing this, using protocol specifically tailored to patients with asthma with persistent airway eosinophilia. And I think that was very good that GSK appeared to have getting lessons from those studies and not have given up at that stage, which have been a great loss to severe asthma. So, and the various people like Jan Pavord were very keen, in fact, to get such a study done, i.e. study patients with these particular biomarkers. So patients with recurrent severe exacerbations and patients that had signs of eosinophil inflammation. And the signs of eosinophil inflammation could either be blood eosinophil count or sputum count or levels of raised FeNO. And I remember we took a long time discussing what we meant by eosinophilic inflammation. But this study really sets mepolizumab onto the road towards a clinical approval. And so in this study, there was, of course, as we know now, a very significant reduction in the exacerbations, and according to the dosage here as shown here. And what was also very important to know was that this very specifically targeted therapy did not have any significant side effects, and particularly side effects that you might expect, like development of antibodies or anaphylaxis and so on. And of course, we don't know, and the question was raised initially as to whether long-term inhibition of the eosinophils in the body would have detrimental effects like cancer or increasing parasitic infections. I think is still a question mark, but there's been no records of those problems at the moment, but perhaps a bit too early. So what I'm going to show you now are the most recent, the most latest publications on those, and you all know that this is the New England Journal publication in 2014, which indeed did reproduce those initial data shown by Professor Pavord. And again, here I think what's happened later on was to use blood eosinophil count, and to me it's always been very interesting that such a simple, very accessible measurement now could be used to enrich the population that's going to respond to this treatment in terms of exacerbations. So as you've seen, so a 50% reduction in exacerbation rates. There's a lot of discussion as to what those 50% remaining exacerbations that are not responding to mepolizumab, and that's probably a point for discussion. The other point of interest here is the effect on FEV1. And although this is statistically significant, particularly towards the end of the of this 32-week treatment, you will agree with me perhaps that this response is very tiny, although significant. So you'd say that mepolizumab has its primary effect on exacerbations, and that makes sense because eosinophils have been linked to is a predictive eosinophil counts, a predictive of exacerbation rates. The other aspect, specifically to severe asthma, which is oral glucocorticoid sparing effect of mepolizumab, you also well aware. So the major point to mention here is that you're getting a reduction in the exacerbation rate, as shown here, perhaps not as the large extent as you've seen before, but still a significant reduction, despite the fact that you are able to reduce the dose of oral corticosteroids in those patients. And here you can see the concomitant improvement in the ACQ-5 score, the overall control of severe asthma. Now, reslizumab has all been shown in the previous talk, and I think the point that I would like to make here with reslizumab is not only there is a similar amount of reduction of exacerbation rate as shown in the mepolizumab study, but here we are seeing also a much bigger effect in terms of the FEV1, or a much more consistent effect, a slightly bigger effect in FEV1. And I think one of the reasons for this is because you will see here that the blood eosinophil count here is put at a higher cutoff level, and that goes hand in hand with some of the data that's been published with mepolizumab that indicates that the degree of effect or the likelihood of having an effect is increased at higher cutoff points of blood eosinophil count. And what blood eosinophil count that we need to use in clinical practice, I think, is a point of discussion later on. Now, of course, there are other members of the T2 family here that we need to discuss, and lebrikizumab is IL-13, which, as I said, has an effect on airway smooth muscle cells. And indeed, the first study that was published in the New England quite a while now, this is 5 years ago, in a group of moderately severe asthmatics. These are not the severe asthmatics that use, but one of the primary things in this study was stratification according to serum pyroxine. Pyroxine is a member of the Th2 gene family, and using a cutoff point that have been determined from previous studies, Genentech did a study which showed as the primary outcome in FEV1, and indeed this population didn't have a lot of exacerbation, so that was a secondary endpoint. But you can see here that the stratification, according to high periostin versus low periostin, showed that the high periostin were those patients who are responding fairly significantly, to about 9% improvement in the FEV1, while there was no effect on the low periostin. So a stratified study that's showing a beneficial effect on FEV1, which is quite rational because of the known effects of IL-13, the biology of IL-13 on airway smooth muscle cells. I show this study, which was a subsequent study that was done in a different group of patients of non-ICS treated asthmatics. So this is, I think, a study mainly done in the US, which patients with fairly mild, very mild airflow obstruction, symptomatic, just reliever medication, but not on ICS. And in this study, you will see that, in fact, there's very little effect. In fact, there are two.
Excuse me, just 2 minutes.
2 minutes, gosh. I'm sorry. And now the study of dupilumab, which the most recent study that was presented at the ERS, and I got the slides from Sally Wenzel, where we are seeing with dupilumab just blocking IL-4 and IL-13, both significant effects on FEV1. And here is the results of the study, which indicated that the improvement in bronchodilator response compared to improvement in FEV1 of the active compound, of the active antibody compared to placebo, appears to be present irrespective of that cutoff point of eosinophil count. You know, whether it's more than 300 or less than 300 cells per microliter, and perhaps a smaller response in terms of FEV1 improvement. And these are the analyzed severe exacerbation rate. And one of the things to note here is how there is a very profound reduction in terms of the analyzed severe exacerbation rate, particularly at the high dose here. And again, here a suggestion that irrespective of whether the eosinophil counts are across 300, more or less than 300. Now, I won't have time, obviously, to go through the non-T2, but I just wanted to point out that one of the problems here, again, and I think drug companies are very difficult to learn the lessons from other drug companies, like mepolizumab, and just to say that those negative studies with anti-TNF alpha, you know, the patients were really not stratified. They were only stratified according to severity, and that's why they were not positive. The only positive finding was that if you look at patients with a given amount of reversibility, greater than 12% reversibility, then there was a trend in less exacerbation in that group. And I think that's a very significant observation on which I think future studies of this sort would should be based on. But of course, one of the problems with anti-TNF antibodies is that the rate of side effects because of cancer, which is very worrying, and brodalumab, an anti-17 receptor antibody, I think that also shows the same thing, negative study, but when you look at ACQ response in terms of whether high reversibility or low reversibility, then you're seeing a tendency for improvement with those with high reversibility. And this is, I'm sure, telling us something. Well, we will have, this is my last slide, so we will have, so we will have, as you've heard, possibly, you know, 3 new treatments, 3 new antibody-directed treatments for severe asthma. I haven't mentioned the anti-IL-4 receptor alpha on this slide, but currently also we have anti-IgE. So the question now, as a clinician, you're sitting in your office and you're seeing those patients with severe asthma, and you say, well, which treatment am I going to give this particular patient sitting in my office? I think that's a big question. I don't have the answer to that, but I just want to show you what are the possibilities. So if we have those 3 treatments that we can use, and I've applied those criteria that we're using now to pick up those patients according to those phase 2 and phase 3 studies that have been done on those antibodies, applying this to the whole 421 patients that we've recruited in the UBioPred. And 15% of that population will not be suitable for those 3 treatments. But there will be quite a big proportion of them suitable for either of these treatments, and he's shown this in terms of the Venn diagrams. And there will be, for example, 15% of that population in whom you will either have all 3 are possible. And then, of course, you have population that in which two of those treatments are possible. You know, you have to choose. But of course, you also have population where only anti-IgE could be given according to this criteria, anti-IL-13 according to this criteria, and anti-IL-5 according to this criteria. So I think there needs to be a lot of work to be done. I think particularly from the drug company, because they are producing those drugs, to tell us which one we should be using, particularly in that group of overlap of those patients. I think that this is not easy. Otherwise, we'd have to do head-to-head comparison of those treatments in an agreed population, between that type of population that seem to be for all those. So let me just finish then. I think targeted therapy to block T2 interleukins have shown beneficial effects in severe asthma patients with evidence of Th2 high. We need better biomarkers to pinpoint patients who will respond to these antibodies and determine which T2 antibody is more appropriate for a particular patient. I don't think that blood eosinophil count, I think, is very useful to tell us the population responding to those compounds, but they don't tell us about the specific compound that antibody that we will respond to. And so, and also finally, I think the non-T2 targets, we need to be much more clear about what those non-T2 targets are, and define the patients that will respond to those particular treatments. Thanks very much for your attention.
Thank you, Professor Chung, for your nice presentation. We have time for just one short question, please.
Thank you, Professor Chung. It has recently been shown that severe asthma correlates with the rupture of aortic aneurysm.
With the rupture?
Of aortic aneurysm.
Oh.
So what this observation adds, both from a clinical standpoint, pulmonary and cardiovascular, should we screen this patient, or at least patient with a particular CCD, as you shown yesterday, for aortic aneurysm as well? Thanks.
I wasn't quite clear what you said. Which antibody has been linked to this?
No, just the fact of being a patient suffering from severe asthma.
Ah, I'm not aware of that association, and I could. I don't know how to answer your question, because, I mean, I'm aware that there is an association between chronic coughing, which I can understand can, you know, the changes in pressure can weaken an already weakened aortic wall or vascular wall. I don't know how to answer your question.
Thanks. So I invite Professor